Hi everyone, and in this video I'll be discussing the next exciting topic, that is pharmacotherapy of diabetes mellitus. Now, why diabetes mellitus is very important? Because one of the commonest non-communicable disease what we see in India and as well as across the world. Now, our India is considered the diabetic capital of the world. The reason is insulin resistance. So, genetic makeup of ours are prone for diabetes, that is particularly insulin resistance. So, what is the problem in diabetes mellitus? The problem in diabetes mellitus is the glucose is high in the blood. What happens if glucose is high in the blood? The problem is an immediate complication like diabetic ketoacidosis can happen, or a long term complication can happen, that is microvascular and macrovascular events. So, patient may come and ask us, sir, why should we keep the glucose under control? What if the glucose is high? The simple reason is if glucose is high, the patient will have complication, immediate and long-term complication. So that's the reason why they should keep the glucose on normal level. Now, we will start this topic basically by understanding certain cases, and then we'll understand pharmacology. So we integrate the things. So let us start. So we have these patients, 3 patients, and we'll start with them. 42-year-old male patient presents with complaints of increased urination, polyuria, increased thirst, polydipsia. Because of that, he will drink more water, and increased appetite. So he will eat more, polyphagia. His investigation are fasting plasma glucose of 180 mg per deciliter and postprandial plasma glucose of 250 mg per deciliter, and urine analysis shows glucose 2+. So the classical symptoms of polyuria, polydipsia, and polyphagia, along with high glucose in the circulation, points towards the diabetes. Now, since the patient of age 42-year-old, so we have to think of the second type of diabetes, that is diabetes type 2. Another patient, 2-year-old, is brought by her mother after routine investigation and random blood glucose is 300. That is also high. So here it's a child, and usually in children's what we see is the type 1 diabetes. We write it as diabetes type 1. A pregnant lady has come with postprandial blood sugar of 250 mg per deciliter. So even in pregnancy we get the diabetes, that is called gestational diabetes mellitus. So that is gestational diabetes mellitus. So let us understand how do we diagnose this thing diabetes and how do we treat diabetes. Let us understand the concept here. So the diagnostic criteria for diabetes according to American Diabetes Association is if the HbA1c, that is glycated hemoglobin, if it is more than or equal to 6.5%, or if the patient has fasting plasma glucose, if it is more than or equal to 126 mg per deciliter, or if the patient has postprandial plasma glucose which is more than or equal to 200 mg per deciliter, or one more criteria is anywhere if they have done random blood sugar, if it is more than or equal to 200 mg per deciliter. Along with that, patient should have the symptoms of hyperglycemia, symptoms of hyperglycemia, symptoms of hyperglycemia. So then we diagnose diabetes. Any of these criteria, it's not like all the 4. Any of this, HbA1c more than 6.5 or equivalent to that, fasting plasma glucose, it is also called as FBS, postprandial more than 200 or equal to that, fasting more than or equal to 126, random more than 200 mg per deciliter. Along with that, patient should have symptoms of hyperglycemia, that is polyuria, polydipsia, and polyphagia. So once we understand the diagnosis, now let us come to another important aspect, the concept. So how to understand the drugs used in diabetes? We need to understand the pathophysiology of diabetes, and that is easier for us. So how do we understand that? To understand that, let us start. The starting is the presence of the glucose in the intestine. So this is the intestine, and you know that sucrose is converted into glucose in the intestine, and the enzyme is called alpha glucosidase. So the enzyme which converts that is called alpha glucosidase. Point number 1. Now the glucose has to be absorbed. Now what happens when the glucose is absorbed? This is the liver. So it will reach the liver. So it will be reaching the liver and stored as glycogen. And there are other tissues, that is the muscles, skeletal muscle. These are the skeletal muscles. And we have other tissues like adipose tissue. Right, these are the adipose tissues, and they will also take up the glucose. So they will also take up the glucose. Now what happens when the glucose is high? Now this is the blood vessel and the glucose is high. Now when the glucose is high, normally what happens? The glucose high is sensed by the pancreas. So we have the pancreas, in that we have the beta cells. This is the pancreas. And when you inhibit a channel called ATP sensitive potassium channel. So when the ATP sensitive potassium channels are inhibited, what happens? The beta cells of the pancreas, they release insulin. So they release insulin. Okay. So that is the normal thing, and with the help of insulin only, the glucose is taken up by the tissues like the skeletal muscle, the adipose tissue, and all the other tissues. So without insulin, glucose cannot be utilized. Another important aspect is, if the glucose is very high, there is a chance that the glucose may be coming in the urine. So this is the nephron. Nephron, we have a transporter, and that is called sodium glucose transporter 2. And one more transporter which is a minor, it is called sodium glucose transporter 1. Now what is their role? Their role, whenever the glucose comes by filtration, they is taken up back. So normally what happens? Normal person, the glucose will not come in the urine, no problem. But the kidneys have a threshold. If the glucose goes above 180, then they will come in the urine. That's why patient will have glucose in the urine, and that's what we saw in the first patient. Yes. Now another important aspect, whenever the glucose is taken up, particularly orally, there is release of something called incretins. So there is release of incretins, and the incretin is the glucagon-like peptide 1. So the glucagon-like peptide 1, now this will also increase the insulin release. What is the role of GLP-1? GLP-1 stimulates satiety. So what do you mean by satiety? It's a sense of fullness. That means you don't want to eat further. Second important thing what GLP-1 will do is, GLP-1 decreases the glucagon secretion. It decreases glucagon secretion. Not only that, it has shown to slow the gastric emptying. Gastric emptying. So this is what is done by the incretins. The major one is glucagon-like peptide. But this GLP-1 is metabolized by some enzyme called DPP4. DPP4 stands for dipeptidyl peptidase 4, and they will make it inactive. They will make it inactive. Now remember, along with insulin, there is one more substance which comes from the beta cells. So remember, insulin and amylin, they come together. So the substance name is amylin. And amylin will also come, and amylin will also do the same three functions, that is stimulate the satiety, decrease glucagon, and slow gastric emptying. Now this glucose release is also controlled by the brain. So brain also plays a major role in controlling the glucose release. You know that sympathetic system will increase the glucose. Now what is the problem if glucose is high in the circulation? We know that there are short-term complications, that is immediate. The patient may have diabetic ketoacidosis. Second long-term complication, the microvascular complication, is diabetic retinopathy. The eyes can get damaged. Nephropathy, the kidneys can get damaged. And neuropathy, nerves can get damaged. Not only that, patient may have the infections and they are not cured, and that may lead to amputations. Or they may have major complications like stroke and MI, and also limb amputations. So that's the reason patients with diabetes has to keep the glucose under control. So the glucose should not rise. It should be within normal limits. and I told you what is the diagnostic criteria. If it is more than that, that is diabetes. So we have to keep it within normal limits. Now you have the pathophysiology. Now you tell me what are the targets and what are the drugs we can use it. So pause this video, just try to analyze this. So we'll go one by one. So number one, what we can do is we can give insulin itself. Now second one is we can give the drug which stimulates amylin receptor. So the name of the drug is called pramlintide. And recently we have the third target, they are called GLP-1 receptor agonist. So we have GLP-1 receptor agonist. That is third. Now you can also inhibit the DP4. So this is another target. And you can also inhibit the enzyme glucosidase. So we have alpha glucosidase inhibitors. Then you can also inhibit the glucose absorption. Yes. And let me give you the examples here only. So it will have an idea now only. D4 inhibitors, they end with gliptins. And GLP-1 agonists, they usually end with glutides. I'll just give a clue. These end with glutide. And alpha glucosidase inhibitors are acarbose, then miglitol, oglibose. And you can also inhibit the glucose absorption, a drug by the name colesevelam. And you know that glucose can be released from the liver with the help of gluconeogenesis. So gluconeogenesis can occur, and from there glucose can be released from the liver, and that is inhibited by a beautiful drug by the name metformin. And uptake, particularly in adipose and skeletal muscles, can be increased by a drug by the name pioglitazone. The name is called pioglitazone. Then you can also inhibit the ATP sensitive potassium channels. They are called as sulfonylureas. And one more group of drug, they are called as meglitinides. Now we have another target. You can inhibit the sodium glucose transporter, and they end with gliflozin. They all end with gliflozin. And recently we have come across a drug which decreases the sympathetic surge that occurs in the early morning, and that is by the name bromocriptine. So bromocriptine. So these are the various targets what we have in treating diabetes. Just pause the video and you will understand this. So let me repeat again: the insulin, the pramlintide, GLP-1 receptor agonist, D4 inhibitors, then alpha glucosidase inhibitors, colesevelam, metformin, pioglitazone, bromocriptine, gliflozins, sulfonylureas, and meglitinides. So these are the different targets to treat diabetes. Sir, why so many drugs to treat diabetes when we have insulin itself? The reason is simple. Even in diabetes type 2, where there is insulin is not able to work because of insulin resistance. That's why we have so many drugs. But in diabetes type 1, there is only deficiency of insulin. That's why the best treatment is insulin. Other drugs will not work except one more drug, that is called pramlintide. So we understood the concept in that, and we understood the targets where the drug works. So next what we are going to discuss are injectable drugs. Usually we'll start with the first drug. It is called insulin. Now what is the mechanism of action of insulin? How does it work? Now what is the mechanism of action of insulin? We know that what is the stimulus for insulin release? Whenever the glucose goes up, who will sense that? We have the beta cells of pancreas, and the beta cells of pancreas, they release insulin. Now what does insulin do? Let us discuss that. So whenever insulin is released, it acts on the cells, and what does it do? Let us discuss that. Now we know that insulin, if you remember general pharmacology, it acts on the receptor called tyrosine kinase. So the receptor on which insulin acts is tyrosine kinase. When that is activated, it will activate the intermediate pathways. And these pathways will activate some gene transcription in nucleus. For example, they can increase the production of GLUT. Suppose it's a liver, what happens? The GLUT production increases. So what happens if GLUT production increases? When the number of GLUT increases, the glucose is taken inside. So the glucose is taken inside. So when the glucose is taken inside, the glucose level in the blood decreases. That's the simplest explanation. So what is our stimulus here? The stimulus is high glucose, and when we use insulin, it will take the glucose from the blood vessel into the cells, particularly the liver, muscle and adipose tissue. So along with that, there is also entry of one more ion when we give glucose, that is potassium. So potassium moves from the blood into the cells. So what is the problem? Hypokalemia. So the problem what we see is hypokalemia. So remember, two important problems what we see when we give insulin are hypokalemia and one more is hypoglycemia. Now, along with that, what is that it will do in the liver? So when we take the liver into consideration, what will this do in the liver? In the liver, it decreases the gluconeogenesis. And it increases glycogen synthesis. It increases glycogen synthesis, right? Along with that, it decreases glycogenolysis. Glycogenolysis. So this is what is done in the liver. So penultimately what happens? All this also decrease the glucose production from the liver. So there is decrease in glucose. What about in skeletal muscles? What happens in skeletal muscle? So in skeletal muscle, there is increase in glucose uptake. There is increase in glucose uptake. And also in the adipose tissue, there also there is increase in glucose uptake. And also there is inhibition of fat breakdown. Inhibition of fat breakdown. And also in muscles, there is inhibition of protein breakdown, because in the absence of insulin, so the bodies try to utilize the adipose, that is fat and protein. So that's why the person will not lose the protein, the person will not lose the fat. So what is the adverse effect? Another adverse effect, what we see when we start insulin, after a few months, patient will have weight gain because fat is not broken down, protein is not broken down, so you will have the weight gain. So this is the concept what we understood when we start insulin. So this is the mechanism of action. The adverse effect are hypoglycemia, then hypokalemia and weight gain. Okay. So this is the adverse effect, and what is the effect in liver, skeletal muscle, adipose tissue? We understood that. So that is the simplest mechanism of action of insulin. Now once we understand the insulin mechanism of action, let us understand the pharmacokinetics. Now insulin is made up of amino acids. It's a protein molecule. So can we give it orally? No. Orally if I give it, it is broken down because it's a protein. So that's why you cannot give insulin orally. And whenever there is renal failure, when you give insulin, you have to decrease the dose of insulin. You have to decrease the dose of insulin. These are two important points you need to keep in your mind. But where do you get insulin from? What are the source of insulin? Where do you get it? Source. So where do we get insulin from? Now you all know that previously that used to come from animal origin. So animal source. So animal origin insulins are the pork insulin and the beef insulins. But you know that if you are taking it from animals and giving to humans, what is the adverse effect we faced? Allergy. Then we came with one more type of insulin. They are called as monocomponent insulin. They are called monocomponent or more purified insulins. So they are purified insulins. So these insulins, they have the advantage of less allergy. So they have the advantage of less allergy. Now moving on to the next one. Then we took the human insulin. So human insulin itself is produced. So how do you make human insulins? There is a technology called recombinant DNA technology. From that we prepared human insulins. Again, what we did is we came with something called insulin analogs. So similar to insulin, human insulin, we have the analogs. They are called human insulin analogs. Example is Lispro. So if I take the example of Lispro, now in the B there is 28, we have proline. So I am talking about the chain of the amino acid that is present in insulin. Normally in the humans, 28 contains proline and B29 contains lysine. So how did they make the insulin? So they exchange this. Lysine is put here and proline is put again into the 29. So that's why it is called Lispro. So lysine and proline, they are exchanged and you get an insulin called insulin analogs. Similar to that, we have others like aspart by exchanging the amino acid. Then we have glulysin, then glargine. So these are the different insulin analogs, and I'm just telling you the source, how did we get the insulin. So you can classify the insulin like this also. Now one more important understanding about insulin is how the insulins are classified. So insulin classification, or we can write it as insulin preparations. So what are the types of insulin preparations we have? The insulin preparation what we have is number one, the rapid acting insulins. So what are these rapid acting insulins? They are called the Lispro, aspart, then glulysin. So we have the Lispro, aspart and glulysin, and remember all these are given by subcutaneous. Now what is their onset of action when we give it, when they will start working? So the onset of action is between 15 to 20 minutes. Within that they will work. Now what is the duration of action? How many hours do they work? They work for only 2 to 3 hours. So duration of action is only 2 to 3 hours. Now recently we have come up with a inhaled insulin which is also rapid acting, and the name is called Afrezza. The name is Afrezza. How do we give this? There is a device for that. Patient has to inhale and it will go to the lung and gets absorbed. Till now we are not able to get a oral insulin because insulin is going to be digested. It's a protein. Afrezza also same onset of action 15 to 20 minutes. Same duration of action 2 to 3 hours. But whenever you are giving Afrezza inhaled, it is contraindicated if the patient is having asthma, COPD, patient is smokers, and patient having lung cancer. So when it is inhaled, it can increase the cough reflexes in this patient. So we don't want to give Afrezza in these patients. And since Afrezza is shorter acting, we cannot depend on that only. We have to add a long acting insulin when we treat the patient. Okay, so these are the insulins. Repeat. Rapid acting insulins are Lispro, aspart, glulysin, which we give subcutaneous, and the only inhaled insulin is Afrezza. Now once we know it, let us understand one more. It is called as the short acting insulin. The short acting insulin is also called as the regular insulin. It is called as regular insulin. So regular insulin, how do we give it? It is the only insulin which can be given subcutaneous and IV. Most of the insulins, please underline this point, are given subcutaneous. Afrezza is inhalation, but regular insulin is the only one which is given IV. That means you can give it in emergencies. Now, what is the onset of action? Onset is between 30 minutes to 1 hour. Sir, why should I know the onset? We can tell the patient when to take it. Usually these are given before meal. So patient can take it 30 minutes before the meal. Now what is the duration of action? Duration of action, when you know it is 2 to 3, so it's around 4 to 6 hours. So the duration of action is around 4 to 6 hours. Now moving on to the another type of insulin. These are called intermediate acting insulin. So these are intermediate acting insulin. So what is that? They are called NPH insulin. So what is NPH stands for? NPH stands for neutral protamine hagedron insulin. Neutral protamine hagedron insulin. And one more insulin is called lente insulin. Lente insulin. So what is their onset? The onset is around 1 to 2 hours. So they will not work immediately. They will onset after 1 to 2 hours. But the duration of action is around 12 to 16 hours. So if we are giving these insulins, how many times in a day I can give? Twice in a day. Now, another important aspect, lente insulin is made up of two insulins. One is called the semi-lente and one more is ultra-lente. So this is a question asked in AIMS exam. How much is semi-lente? 30%, and it is amorphous. And crystalline is 70% in this, and that is crystalline. So that is called intermediate acting insulin. So this was the MCQ asked. Now the last insulin what I am going to discuss, they are called the long acting insulins. The long acting insulins. What are these? They are called glargine. So they are glargine, detamir. Now these two insulins are the longer acting. The onset of action is around 2 to 4 hours and they work for 24 hours. So the duration of action is 24 hours. Please remember, all the insulins are usually supplied at neutral pH. Glargine is the one which is supplied as acidic pH. So it is present in acidic pH. Glargine and detamir are not mixed with other insulin. So other can be mixed but not this glargine and detamir. Again a question for you. And they can also ask you which is available at acidic pH. It is glargine. The longest acting insulin what we have is by the name degludec. It also has an onset 2 to 4 hours, but the duration of action is around 42 hours. So the duration of action of this is 42 hours, and that's the specialty of that. So longer acting insulins are also called as peakless insulins. They don't peak. Or they are also called as basal insulins. So these are the insulin preparation depending on the onset and duration of action. You can see here. So let me just summarize the things for you. So insulin preparations, we have rapid acting. The rapid acting are lispro, aspart and glulisol. They are given subcutaneous. Inhaled is called Afrezza. Then short acting insulin is regular and it can be given subcutaneous as well as IV. Intermediate is called NPH insulin, and one more is lente insulin made up of semi-lente and ultra-lente. The longer acting insulins are glargine, detamir, not mixed with other insulins. The longest acting is degludec with a duration of 42 hours. These are the points you have to keep in your mind. Once we understood the insulin preparation, it's important that we understand the uses of insulin. So let me write the uses of insulin. Insulin is the primary drug for managing diabetes type 1. Second, it is used for diabetes type 2. Number 3, it is used in gestational diabetes. Gestational diabetes, it's the major drug and the only drug we use in gestational diabetes. Now another important aspect is, suppose a patient is on oral drug. Sometimes we have to shift the patient to insulin for a brief period. What is a brief period we shift the patient to insulin? It is during surgery. Patient is in stress or patient is having some infection, so their insulin requirement is high. Once that is over, we can shift back to oral drugs. So from oral drug, we shift to insulin during surgery, during stress and infection. So these are the uses of insulin. Now what are the emergency use of insulin? So let me write like this. Emergency use. So the emergency use of insulin is, it is used in a condition called diabetic ketoacidosis. diabetic ketoacidosis. Now, as the name tells you, diabetic ketoacidosis, the glucose is very high in the circulation. Now, when the glucose is very high, it comes in the kidney and patient will have osmotic diuresis. Because of osmotic diuresis, patient will have dehydration. So when the glucose is very high and insulin is not there, there is excessive production of ketone bodies. So there is ketone bodies produced, and because of that, patient will have acidosis. So this is in simple manner. So patient glucose is high, patient is dehydrated and he is having acidosis. So how do you manage diabetic ketoacidosis? Now manage by using number one, IV regular insulin. So give intravenous regular insulin. So that is the main important aspect. Second, another important aspect is patient is dehydrated, you have to give the intravenous fluid. So give the IV fluids. Now what happens when we give insulin? When we start insulin, I told you potassium may come down. So you have to monitor potassium levels. If potassium levels are going down, you have to give potassium chloride. Now many a times acidosis has to be managed, and that is managed with sodium bicarbonate. So that will manage acidosis. And one more important thing is, when we have given regular insulin, IV fluid, potassium chloride, sometimes we have to start antibiotics because certain infections can trigger this diabetic ketoacidosis, otherwise not required antibiotics. So major therapy is insulin, fluids, potassium only if it is hypokalemia, and to correct acidosis we use sodium bicarbonate, and that is the management of diabetic ketoacidosis. Another emergency use of insulin is called non-ketotic hyperosmolar diabetic coma. Now this is particularly seen in diabetes type 2 patients. Diabetic ketoacidosis particularly mainly seen in diabetes type 1 patients. In non-ketotic hyperosmolar diabetic coma, the problem is the osmolarity has increased. So the major management will be IV fluids. And compared to diabetic ketoacidosis, there is less need of insulin, but we give insulin, but less need. So less need of insulin and less need of potassium chloride, and there is no acidosis, so no need of sodium bicarbonate. So these are the difference between managing the diabetic ketoacidosis and this. Another important emergency use of the insulin is hyperkalemia. So hyperkalemia management, whenever the potassium goes up, and we know that we need to bring it down, otherwise arrhythmias can happen. So what are the treatment strategies? What we have is salbutamol. So salbutamol is given in the form of nebulization. So it is given in the form of nebulization. Along with that, we will give insulin. So what is the insulin we used? It is a regular insulin. Along with that, we add dextrose. The question is, why do we have to add dextrose? Because patient is not a diabetic. He has come with hyperkalemia, but if I give insulin alone, he will go for hypoglycemia. So you have to add dextrose with that. Now, if the patient has ECG changes, then you have to add another drug that is called calcium gluconate. So one of your exam that asked, all are used in the management of hyperkalemia. They are given salbutamol, insulin, calcium gluconate, and they had given magnesium sulfate. Remember, magnesium sulfate is not used in managing hyperkalemia. So what are the three emergency uses of insulin? Hyperkalemia, then non-ketotic hyperosmolar diabetic coma, and one more is diabetic ketoacidosis. So remember, for emergency use, what we use is the regular insulin, because that is the only insulin that is given intravenous, right? So once we understood the uses of insulin, let us understand the adverse effect. You know the concept already. What are the adverse effect? The major adverse effect is hypoglycemia. Patient will have hypoglycemia. But how will the patient know hypoglycemia? Because he will have the symptoms of hypoglycemia, that is tremors, palpitations, and patients will have sweating. So these are the symptoms of hypoglycemia. These are the symptoms. But in a diabetic patient, we don't give non-selective beta blockers. So we don't give non-selective beta blockers because they cause hypoglycemic unawareness. And we have discussed this concept in beta blockers also. I am just correlating this here. So hypoglycemia can be seen, and when the hypoglycemia is seen, patient will have the warning signs. But when we use non-selective beta blocker, suppose a patient is diabetic and hypertensive, or a patient has migraine, we have given non-selective beta blocker like propranolol, patient will not have tremors and palpitation. Only thing he will have sweating. So that is called hypoglycemic unawareness. Okay, let us continue. Suppose a patient has hypoglycemia, what is the treatment? So whenever you see a patient with hypoglycemia, what is the treatment? Now it depends on whether the patient is conscious or the patient is unconscious. So when the patient is conscious, obviously you can give oral. So oral, what you can give is the chocolate, sugar, honey, then candy, all those things can be given. So the sugar items can be given. But if the patient is unconscious, so if he is at home, then many places they are given IM glucagon. So IM glucagon can be used because it's easy to use. So they can open the glucagon injection, just prick it into the muscle. Suppose a patient in hospital and has hypoglycemia. In the hospital, it depends whether the patient is having IVSS or not. So if there is no IVSS, obviously you have to give IM glucagon if you don't get IV line. If the IVSS is there, then better to give the dextrose, that is glucose. So you can give dextrose. So this is how we manage the hypoglycemia due to insulin administration. Now other adverse effect what we see with insulin is, the insulin when we use it, it can cause weight gain. I told you what is the reason for that weight gain. Second problem is it can cause allergy. Now allergy is not a problem nowadays because we get purified insulins now, not animal origin. So animal origin insulin used to cause that allergy, not now. Another important is hypokalemia. So when we use insulin alone, there is a risk of hypokalemia. The third problem, another problem is edema, and that is mild cases. It's a mild edema and that is due to sodium retention. So not seen in every patient. Now another important concept is insulin can cause lipodystrophy. Now what do you mean by lipodystrophy? You know that dystrophy means both hypertrophy and hypertrophy is seen. The problem is when you give insulin subcutaneous at the same site repeatedly, that is the problem called lipodystrophy. If I give the insulin again and again at the same site. Now what are the sites where we give insulin? Okay, let me discuss what are the sites of giving insulin. Sites of giving insulin is in the buttocks, then the upper outer arms, then another important is 2 inches away from umbilicus. So we need to give it in the abdomen, that is abdomen. And one more is the anterolateral aspect of thigh. So we don't give it into the medial aspect of the thigh because medial aspect we have a great vein, that is great saphenous vein. So these are the sites recommended by ADA, American Diabetes Association. These are the sites to give the insulin by subcutaneous route. So number 1 in the buttocks, upper outer arm, abdomen, don't give it to the umbilicus, and anterolateral aspect of the thigh. The problem is when we give insulin, suppose this is the umbilicus, suppose if you are giving the insulin at the same site, so then the problem of lipodystrophy occurs. So the better way is to rotate the site, so Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, like this. So if you are rotating the site, this problem will not happen. Not only in the abdomen area, you can rotate whatever sites we have shown in the slide. So this is the problem called lipodystrophy, what we see. So we understood the adverse effect of insulin. Let me repeat again, the major adverse effect is hypoglycemia, and I told you how to manage that. Weight gain, allergy, not seen nowadays, hypokalemia, edema, and lipodystrophy. Now once we understand this, it's important, how do we give insulin? What are the devices? So insulin is given with a special syringe that is called insulin syringe. So we can give it with insulin syringe. Now nowadays, the problem with insulin syringe is patient has to take the vial, then load the drug and then take the drug. So that's an inconvenient for an elderly patient. So nowadays what we have is a device called insulin pen device. So it's a device where you just open the cap, you can adjust the dose, how much is required, and then prick it. Then we have continuous insulin pump device. So these are also available. So these are the different ways of delivering insulin: insulin syringe, insulin pen device, insulin pumps. These are the ways to deliver insulin. The advantage is it's more of patient convenience. So these insulin pump devices, they can be carried by the patient, and whenever they want, they can press the button, that much of dose of insulin is released. So they need not carry like pen also. So it will be attached. They can carry in pocket also. Yes. So that is about the insulin concept. Once we understood the insulin concept, let us understand the second one. And the second target are called as amylin receptor agonist. So the second target is called amylin receptor agonist. Again, I will clarify this. Amylin and insulin come together. Now, what is the role of amylin? It stimulates satiety, it decreases glucagon, and it slows gastric emptying. So the drug is called pramlintide. The name is pramlintide, and the name itself as amylin, amylin for amylin, tide means it's a peptide. Now, since it's a peptide, pramlintide is given subcutaneously. Now, pramlintide has no hypoglycemic effect. It will not produce hypoglycemia. No hypoglycemia. One specialty of the drug is, it is approved for both diabetes type 1 as well as diabetes type 2. You take the insulin, which is used everywhere. Another drug which can be used for 1 and 2 is pramlintide. Except this, all other drugs what we discussed, they are only approved for diabetes type 2. Right. Now, what does it do? It stimulates satiety and decreases glucagon. It decreases glucagon and slows gastric emptying. Slows gastric emptying. These are seen with the amylin. So when we use pramlintide, these are seen for us. But this pramlintide is contraindicated in a patient with diabetic gastroparesis. So most of the diabetic patients have this problem, diabetic gastroparesis. So what is the meaning of gastroparesis? The intestine, the stomach is not moving. So patient will have constipation like symptom because of diabetes. Now what is the problem if I use it? Already the drug slows gastric emptying and a patient has diabetic gastroparesis, so it will worsen that. So that in that patient we don't give pramlintide. So the name of the drug is pramlintide. Is an amylin receptor agonist given subcutaneous, approved for both diabetes 1 and diabetes type 2. So the third target what we are going to discuss, the third target are called as GLP-1 receptor agonist. These are called as GLP-1 receptor agonist. So we have two GLP-1 receptor agonist derivation. The one which is because of the human GLP-1 backbone, from this it is derived. And one more is the derivative of exendin 4 backbone. So actually this discovery started with an animal called Gila monster that saliva contained this exendin 4 and that had GLP-1 receptor agonist. So those drugs which are derived from exendin 4, the example says exenatide. The name is exenatide and one more is called lixisenatide. Lixisenatide. Now the human GLP-1 backbone which are GLP-1 receptor agonist, they are called the drug by the name liraglutide. It is called as liraglutide. Second one is called albiglutide, and dulaglutide, and a drug called semaglutide. So the GLP-1 agonist which have the human GLP-1 backbone, and you see the name, all their name ends with glutide. So liraglutide, albiglutide, dulaglutide and semaglutide. The exendin 4 backbone, they end with tide, but they have this XA in the name, exenatide, lixisenatide, that's it. But glutide have the same ending. Since they are tied, you cannot give them orally. All these GLP-1 receptor agonists are given subcutaneous. But remember, semaglutide is recently approved, which can be given both subcutaneous as well as oral. So next exams will be based on this. Based on the oral or it is subcutaneous. So all others are given subcutaneously. The drug which can be given both is semaglutide. Now, what are their actions? Again, I am telling you, they increase insulin release. They increase insulin release. Compare that with pramlintide. Will it increase insulin release? No. Second, they also stimulate satiety. They also decrease glucagon. And also they slow gastric emptying. They also slow the gastric emptying. These are the actions what we see. Now compared to pramlintide, what is the difference here? They increase insulin release. But pramlintide is not going to increase the insulin release. That is the difference. Now what is the adverse effect of these drugs? The major adverse effect of these drugs are they can increase the risk of pancreatitis. So they can increase the risk of pancreatitis. Second, they increase the risk of medullary carcinoma of thyroid. So these risks are increased by them. But what is the contraindication where we should not use them? Number one, in a patient with diabetic gastroparesis. Can you tell me the reason for that? The reason is, yes, same reason. They slow the gastric emptying. They are also not used in a patient with MEN syndrome. So MEN syndrome, you can see the medullary carcinoma of thyroid. So patient with MEN syndrome, you should not use it. That is about the GLP-1 receptor agonist, and remember they end with glutide. But one specialty I just want to inform here. These drugs, they don't produce hypoglycemia. No hypoglycemia with these drugs. Sir, what is that called as? They are called anti-hyperglycemic agent. Then when will hypoglycemia increase? When you combine these drugs with insulin, then only the risk increases. Otherwise, they don't cause hypoglycemia themselves. Sir, what do you mean by that? Now, understand this is a normal glucose level and the glucose goes up. When the glucose goes up, the drugs will bring the glucose to normal, and those are called anti-hyperglycemic agent. But there are certain drugs which will bring the glucose further down. They are called hypoglycemic agent. Example is insulin. But other two drugs what we discussed right now, pramlintide as well as the glutides, they are anti-hyperglycemic agent. They don't cause hypoglycemia significantly unless you combine with insulin. So no hypoglycemia, but one advantage is they cause weight loss. Now, because of this, there are two drugs called liraglutide and one more is called semaglutide. These are the drugs which are used to treat obesity. They are approved to manage obesity, separate drug. Not only for diabetes, they are also approved for obesity. Now, another important concept is these slow the gastric emptying time. So, there is a condition called short bowel disease. Now, short bowel disease, the bowel is short due to surgery or something like that. We do surgery. And when there is short bowel, what happens? Whatever the person eats, immediately it will come to the intestine and gets emptied. So, for that patient, we want to retain the food inside. We want to prolong the gastric emptying so that we have a drug by the name teduglutide. The name is teduglutide, guys. So what is it? It's a GLP-2 receptor agonist. And it is approved not for diabetes, it is approved for short bowel disease. So how does it help? By slowing the gastric emptying. In short bowel disease, that is fast, it will slow it. Right. So these are the liraglutide, semaglutide and teduglutide drugs. Okay, so whatever I discussed till now, they are all injections, that is insulin, pramlintide and glutide, except semaglutide, which can be given as injection as well as oral. Now, other drugs, what I am going to discuss now, they are all oral drugs. So let me write the oral anti-diabetic drugs. Oral anti-diabetic drug. So in that, let us continue the target. Fourth one are called as biguanides. They are called as biguanides. In biguanides, we have a drug by the name metformin. The name is metformin. And one more drug is called penformin. Now, they end with formin. And this is not used because the drug increases the lactic acidosis. So because of this problem, the drug is not used nowadays. Not used. So what is the major drug we use here is metformin, one of the beautiful drug of century. Okay, sir, what is the mechanism of action of metformin? Mechanism of action. Now metformin, let me write here. Metformin has three major mechanisms of action. What is that? It stimulates an enzyme called AMP kinase. It stimulates an enzyme called AMP kinase. Particularly the site of action is in the liver. It inhibits gluconeogenesis. It inhibits gluconeogenesis. So what happens if you inhibit that? The glucose is not produced from the protein or amino acids. So when there is no gluconeogenesis, there is decrease in hepatic glucose output. It decreases hepatic glucose output. So if they ask in the exam what is the major mechanism of action, this is the major mechanism of action of metformin. That's the major, decreasing hepatic glucose output. What are the minor mechanism of action? It inhibits the glucose absorption. So it inhibits the glucose absorption from the gut. What is the third mechanism of action? Very much important, it increases the glucose uptake. Now, who has to take glucose inside, particularly the muscles and adipose tissue? There they increase the glucose uptake. So when you increase the glucose uptake, it acts as insulin sensitizer. So metformin is an insulin sensitizer. Now this insulin sensitizer function is very good, and we also use it in the management of PCOD, where you see insulin resistance. So basically metformin has three mechanisms: decreasing hepatic glucose output, inhibiting glucose absorption from the gut, and it is an insulin sensitizer. So it will help the insulin to take up the glucose into the cells. Now the question always asked is, will it increase the glucose? The question always asked is, will it increase the insulin secretion? Never. It is not going to increase the insulin secretion. Remember, it's an insulin sensitizer. Once I know the mechanism of action, what is the adverse effect of metformin? Very, very common. The most common problem is the GAT upset. So patient will complain of the gastritis and the bloating issues. Second problem is it has shown to decrease B12. Patients may have B12 deficiency. But the dreaded complication is there is a risk of lactic acidosis. There is a risk of lactic acidosis. So there is a risk. Now the point here is, where is the risk going to increase? So what are the factors increasing the risk of lactic acidosis? The risk are whenever there is increased lactate production. So which situation lactate production increases? Whenever there is hypoxia, CHF, sepsis, they can increase the risk of lactate production. And that's what I told you, whenever there is surgery or sepsis, better to shift the patient from this metformin to insulin. Second, there is lactate metabolism is interfered. Now who is going to metabolize lactate is the liver. So if there is liver failure and lactate is not handled properly, again there is lactic acidosis. Or there is increase in metformin levels. And when the metformin level increases, the lactic acidosis increases. So where do you see it? You see it in renal failure, because metformin is thrown out by the kidneys. So remember, whenever there is increase in lactate production, whenever the lactate is not removed effectively, or whenever the metformin increases in renal failure. So these are the conditions where the lactic acidosis risk increases. Will this increase the risk in elderly? Obviously, because elderly patients, obviously the renal function and kidney functions are down, so there is a risk. The question is, will the smokers have the risk of this problem? No, they don't have this risk. This is one of the questions asked. Another important aspect we need to understand is, whenever there is renal failure, should we use metformin or not? It's a commonly asked question in exam. Now, if the GFR is between 30 to 45 ml per minute, then you have to decrease the dose by 50%. By 50%. This is the point. Now, if the GFR is less than 30 ml per minute, and then you have to stop metformin. Many times in the exam, they will give you creatinine levels. So, if the serum creatinine level is more than 1.5 milligram per deciliter in a male, or if it is more than 1.4 milligram per deciliter in a female, then these are the situation where you have to stop the metformin. You have to stop the metformin, right? So this is the point why you need to understand. It's not only a pharma question, it's a medicine question also. Remember, metformin, very beautiful drug. So where do you use it? Where do you use it? It is used in diabetes type 2, correct? Then it is used in PCOD. The reason is it's an insulin sensitizer. So apart from diabetes, it is also used in PCOD, because in PCOD there is insulin resistance and it can overcome, metformin can overcome that. Okay, so once we know metformin concept, let us move to the next oral antidiabetic drug. And the fifth target, these are called as thiazolidinediones. So a bigger name, they are called as thiazolidinediones. So don't worry about the big name of this, but you have to remember the drug name. So there are two drugs mainly. The name is called pioglitazone. At least remember the glitazone. So it ends with glitazone. And one more drug is called rosiglitazone. Rosiglitazone. Now recently we are not using rosiglitazone because it is banned. Why it is banned? It has caused increase in cardiovascular deaths. So rosiglitazone has been banned because it has shown to increase cardiovascular deaths. Now what we have currently is only one thing, that is pioglitazone. So let us understand the mechanism of action of pioglitazone. Pioglitazone, as the name suggests, it is a drug which acts through nuclear receptor, and that is called PPAR gamma. So PPR stands for peroxisome proliferator activator receptor gamma. Now, is there any other diabetic drug which can also stimulate that? And that is called telmisartan. So telmisartan also stimulates this, that is PPR gamma. Now what happens when you stimulate that? There is increase in production of insulin responsive genes. Insulin responsive genes. Now where do you see this response? It is mainly seen in adipose tissue. So if they ask in the exam what is the major site of action of pioglitazone, it is mainly in the adipose tissue, and also it acts on skeletal muscle, but that is lesser compared to adipose tissue. So the major action is on adipose tissue. So what happens if there is increase in insulin responsive genes? There is increase in insulin sensitivity. There is increase in insulin sensitivity. So what is the advantage if there is increase in insulin sensitivity? You can manage insulin resistance. So this will decrease insulin resistant problem. So that is the mechanism of action of pioglitazone. I will repeat again. Pioglitazone stimulate the nuclear receptor PPR gamma. It increases insulin responsive genes, which will increase the insulin sensitivity, and thereby it decreases the insulin resistance. Now the major site of action is adipose tissue, and there is one more drug, telmisartan, which is a PPR gamma agonist. Now whenever you think of PPR, please remember there is also something called PPR alpha. Now who will stimulate PPR alpha? We discuss these drugs in the blood topic. They are called fibrates, and we use them in dyslipidemia. So these are called lateral reading. So once I understand pioglitazone, you need to summarize the thing. What is that? There are only two insulin sensitizers what we have. One is metformin, one more is pioglitazone. Now remember, pioglitazone is only approved for diabetes type 2. And what is the adverse effect? This is the most commonly asked question in exam. What is the adverse effect? Now, will it cause hypoglycemia? No. But it causes sodium and water retention. Sodium and water retention. Second, it will cause the weight gain. It will cause the weight gain. No hypoglycemia. No hypoglycemia. Now, since it causes sodium and water retention, you cannot use this, and it is contraindicated in a patient with CHF. So, heart failure, you are not going to use pioglitazone. It causes weight gain and no hypoglycemia. Third is another important aspect is it has known to increase the risk of bladder cancer. So, bladder cancer has risk is increased. The meaning is you should not use in a patient who has a family history of bladder cancer or a patient who is coming bleeding per urethra. You should not use it. So that is a warning called as black box warning given to this drug. So that is the black box warning given to the drug. Another important adverse effect is the drug is known to increase the risk of osteoporosis. Now this osteoporosis will lead to fractures particularly in females. The studies have shown the fractures have been increased more in females compared to males. Right? So osteoporosis leading to fractures in females compared to males. And rarely the drug is known to produce edema called macular edema. So these are the adverse effects what we see with the pioglitazone: sodium and water retention, weight gain, no hypoglycemia, increased risk of bladder cancer, osteoporosis, which will lead to fractures, particularly in females, more in females compared to males, and rarely macular edema. And it's one of the beautiful insulin sensitizer. Right. So the question here is, what about metformin, sir? You didn't discuss metformin effect on the weight. Remember, metformin effect on the weight is, it's called weight neutral. Most of the guidelines nowadays is considering metformin as weight neutral, and also it has no hypoglycemia. It produces no hypoglycemia. It's an anti-hyperglycemic agent. So don't worry, at the end of the topic we'll be discussing what drugs are going to cause weight loss, weight neutral, and who are going to cause hypoglycemia, all those things. So that is about the drug pioglitazone. Now, once we understand pioglitazone, the sixth group of drug what we are going to discuss, they are called as sulfonylureas. So they are called as sulfonylureas. Now, as the name suggests, they are sulfur derived. So what we can expect? Allergy. Now, there are two generations of that. The first generation, and we have the second generation. What is that first generation we have? The first generations are not used nowadays, but maybe it is used in MCQ. That's why I'm writing. They are called chloropropamide. Chloropropamide, it has some characteristic adverse effect. What is that? It is known to produce disulfiram like reaction, and it is known to produce a jaundice called cholestatic jaundice. And also it is known to produce dilutional hyponatremia. So these are specifically seen with chloropropamide. Now another drug is tolbutamide. It is called as tolbutamide. The specialty of the drug is it is highly plasma protein bound drug, and it follows one other pharmacokinetic importance is saturation kinetics. It follows saturation kinetics. You remember the watt power mnemonic, you will remember that. Coming to second generation, this is the one which we are using nowadays for treating diabetes. The name is glibenclamide. Remember, they start with gli. So glibenclamide is also called by the name glyburide. Then we have glipizide and gliclazide, and one more drug, glimepiride. Now glimepiride is the most potent. Now what do you mean by most potent? Obviously it is used at lesser dose. So sulfonylureas, we have two generations. The older ones are not used nowadays. Chloropropamide, one of the longest acting sulfonylurea, and it has some adverse effect. Tolbutamide, no. Now what we are using is all starting with glimepiride, glibenclamide, glipizide, and gliclazide. So once we know this, let us understand the mechanism of action. How do they work? So mechanism of action, let me write here. Let me write the beta cell of pancreas here. Yes, so this is the beta cell of pancreas. Now what happens? Whenever the glucose enters to the beta cells of the pancreas, now you know that glucose is converted into ATP. Now there is something called ATP sensitive potassium channels. So when the ATP comes, there is a channel called ATP sensitive potassium channel. Let me write that. ATP sensitive potassium channel. They are called like this. So what is their role? Their role is to put potassium outside. You know that when the potassium goes outside, the cell will lose the positive ions and the cell will become negative. That is hyperpolarized. That means beta cells will not work or they will not release insulin. So ATP will block the potassium channel. So what happens? The potassium stays inside, and along with that the calcium enters inside. So what happens? There is storing of insulin inside. So the calcium will come and there is release of insulin. So there is insulin release. So when you block the ATP sensitive potassium channel, they will close the potassium going out and calcium will enter and insulin release occurs. This is normal. So this function is enhanced by drugs called sulfonylureas, and one more group of drug which we will discuss later. They are called as meglitinides. So they will act by inhibiting the ATP sensitive potassium channels. Now, by inhibiting that, the calcium enters, insulin release occurs. So, how much of beta cell mass should be present for these drugs to work? At least 30% of beta cell mass should be present. Then only the drugs will work and release the insulin. At least 30% of beta cell mass. Sir, will sulfonylureas work in type 1 diabetes? It's a rational question. No, because in type 1 diabetes, the pancreatic beta cells are destroyed, are not there. So how come the drugs will work? No, they are not effective. I will ask you one more. In hypertension, we have discovered a drug called diazoxide. Now, diazoxide will act as potassium channel opener. So when we use this diazoxide, it's a potassium channel opener. So potassium goes out. Now tell me what happens if potassium goes out? The insulin is not released. So diazoxide decreases insulin release. Now what happens if you decrease insulin release? What happens? The patient will have hyperglycemia. The patient will have hyperglycemia. So the adverse effect of diazoxide is hyperglycemia and also decrease insulin. So what we did, we took the advantage and started treating a patient of insulinoma with that. So the name is diazoxide, which we discussed in hypertension. I am correlating here so that you will understand in a better manner. So that is about the mechanism of action of sulfonylureas. They inhibit ATP sensitive potassium channel and they release the insulin. Okay. So what are the other adverse effects of these drugs? Now, as the name suggests, these drugs are sulfa, so they can cause allergy. Second, they increase the insulin release and they are also drug which cause hypoglycemia. They cause hypoglycemia. And what about the weight, sir? They cause weight gain. They cause weight gain. And third important problem is when there is sulfonylurea induced hypoglycemia. Do we have an antidote for this? Do we have an antidote for this? Yes. The antidote can be asked in the exam. The antidote is octreotide. It is called octreotide. This is another MCQ based question that can come in your exam. So allergy, hypoglycemia, weight gain. And if there is sulfonylureas hypoglycemia, the antidote is octreotide. So if there is hypoglycemia, you can give glucose only. But if there is toxicity and hypoglycemia because of sulfonylurea, the antidote will be octreotide that can be used. So that is about sulfonylureas. Moving on to the next target, the seventh target, they are called as meglitinides. They are called as meglitinides. They have the same mechanism of action of sulfonylurea. They inhibit ATP sensitive potassium channels. There are two drugs. One is called repaglinide and one more is called nartaglinide. Nartaglinide. Second important point is they have a very short half-life of 1 to 2 hours. Now if they have a half-life of only 1 to 2 hours, where are you using that? Think. We are using it to decrease FBS or PPS, or how many times in a day are we using it? Can we use it in 12 to 24 hours or 12 times a day? No. They are mainly used 3 times a day to decrease postprandial blood sugar. So whenever the person takes the meal, he will take the drug and they mainly reduce postprandial blood sugar. So what is the adverse effect? Similar to sulfonylurea, they also decrease glucose, hypoglycemia, and they also cause weight gain. That is meglitinide for you. Moving on to the eighth target, they are called as alpha glucosidase inhibitors. So they are called alpha glucosidase inhibitors. I told you, if this is the gut, this is the intestine. So whenever the sugar is taken, that is sucrose, is converted into glucose. And who will do that? It is alpha glucosidase. So if I inhibit this enzyme, sucrose will not become glucose. Now what are the drugs? They are called as acarbose, then miglytol and oglibose. So we have acarbose, miglytol and oglibose. They are alpha glucosidase inhibitor. The point here is, what is the adverse effect of this drug? Now when you don't digest the sugar, sucrose, they can cause bloating as adverse effect. Patient may complain of bloating. That is the main problem with these drugs. Now where do you use it? Yes, we use it in diabetes type 2 only. But their advantage is they are mainly known to decrease the postprandial blood sugar. So when we take along with food, it will decrease the postprandial blood sugar. The reason is when a patient eats the food, it becomes sucrose then glucose. So the drug has to be taken along with food. So how do you take these drugs? Along with food. Yes. How do you take these drugs along with food? First of all, patient has to take 1 or 2 bites, then take the tablet and continue the meal. That is the meaning with along with food. So that is the alpha glucosidase inhibitors. One more clinical application they can ask in the exam. Suppose patient is on insulin and patient is taking acarbose. Okay. And patient now presents with hypoglycemia. He has hypoglycemia. The question here is, if he has hypoglycemia, can we use table sugar? Can we correct that with table sugar? I told you in insulin, whenever there is hypoglycemia, you can give sugar or you can give chocolate, candy, honey like that. Can we give table sugar? No. Please think and tell me. No. Why? Table sugar is sucrose. If the patient is already on this, sucrose will not become glucose and hypoglycemia is not corrected. That is the clinical application of this point. So guys, the age target is alpha glucosidase inhibitors. Okay, so the 9th target, what we are going to discuss, they are called DPP-4 inhibitors. So they are called as DPP-4 inhibitors. What is DPP-4? Dipeptidyl peptidase 4. And what does it do? It will metabolize the glucagon like peptide 1 is metabolized to inactive with the help of DPP-4. So if I inhibit this enzyme, the GLP-1 activity increases and it will produce the beneficial effect like increasing insulin release by producing satiety, slowing gastric emptying, and third by decreasing glucagon. So these are all given orally and they end with the name gliptin. Examples are sitagliptin. The name is sitagliptin. Another drug is called saxagliptin. Saxagliptin, and one more is called alogliptin. Alogliptin, and most important in your exam is linagliptin. Why linagliptin is very much important? Because linagliptin undergoes bile elimination. So another advantage is it undergoes a circulation, that is enterohepatic recycling. So what is the advantage of this? The advantage is, suppose a patient has renal failure, can we use this drug? Yes. The reason is it is metabolized by the liver, it is going in bile, so no problem in renal failure. So the question asked in multiple exams is, it doesn't require no dose reduction in renal failure patient, and that is linagliptin failure. Right, and remember all the drugs end with gliptin, and one more gliptin is vildagliptin. Vildagliptin. One more gliptin is there which is extensively used in India, that is called teneligliptin. Teneligliptin is Japan approved, not US FDA approved. That's why most of the standard textbooks will not mention that. Now, once we know this, what is the adverse effect of these drugs? Most common is they can produce nasopharyngitis symptoms, that is running nose. Second, very rarely they can produce a problem called pancreatitis. So remember one more group of drug which can cause pancreatitis, that is GLP-1 receptor agonist. So that is about the DP4 inhibitors. Moving on to the next target, the 10th target. The 10th target is what we mean by SGLT2 inhibitors. So SGLT2 inhibitors, the name itself is telling you sodium glucose transporter 2 inhibitor. So what is their site of action is in the nephron. So this is the nephron and this is the transporter. So it can take up sodium, it can take up glucose, and that is called SGLT2. So this is SGLT2, the major transporter, and a minor transporter is also present, that is called SGLT1. So the drugs target this and inhibit this. What happens if you inhibit this? You are losing sodium. So there is loss of sodium and there is loss of glucose. So there is glucose loss in the urine. Now the sodium loss and glucose loss, there may be advantage and disadvantage to the patient. What is the advantage? When you lose sodium, obviously you are losing water, so it will produce diuretic effect. So the drugs have diuretic effect, and that is the reason they have shown to be beneficial in heart failure patient. They are beneficial in heart failure patient, and they have shown to reduce the cardiovascular mortality in CHF, and they are also shown to decrease hospitalization in patient with heart failure. Again, when you are losing glucose, that means they also can cause weight loss. They can also cause weight loss. This is the advantage. Now, what is the disadvantage or adverse effect when you lose the glucose? When you lose the glucose, patient will have UTI because the glucose is a good culture media for bacteria to grow. And second, the genital mycotic infection, fungal infection or mycotic infections, particularly the candidiasis, is seen in this patient. So this is the advantage, diuretic effect and weight loss. Adverse effect is UTI and genital mycotic infection when you lose sodium and glucose. So this is the mechanism of action. So once we understand this, let us understand the drugs, SGLT2 inhibitors. Drugs, what are these? They are gliflozins. Empagliflozin. The name is empagliflozin. Remember they end with gliflozin. Then we have DAPA, canagliflozins. So they are empagliflozin, dapagliflozin, and canagliflozin. Recently we have ertugliflozin in the market. And remember, all are oral drugs. And let me repeat again, what is the adverse effect of these drugs? The adverse effect, which is most common, what we see is the genital mycotic infection. Genital mycotic infection, that is the candidiasis. Second, UTI. So this is again a common question. Which drugs, diabetic drug cause UTI? It's a common question. The other rare problem are, the rare adverse effect are, they can produce a gangrene called Fournier's gangrene. Fournier's gangrene. And they can also produce euglycemic ketoacidosis, and another important problem, especially seen with canagliflozin. Canagliflozin has shown to increase the risk of lower limb amputations. Lower limb amputation is increased risk by canagliflozin. They have done study where they have shown to increase the risk. The drug is canagliflozin. So the adverse effect, most common, I told you, rare. Now there are also some reports when we use these drugs. There are certain reports that these drugs also produce osteoporosis. So SGLT2 inhibitors also produce osteoporosis and leading to fractures. So patients may have fractures with that. Now this is an area of interest for the examiner because these are new drugs and they have shown beneficial effect in heart failure. And that's the reason why these questions come. What is the adverse effect and rare adverse effect also being asked. And even recently the osteoporosis, what drugs will produce is also being asked. And remember they end with gliflozin. Will they cause hypoglycemia? No. Will they cause weight gain? No, they cause mild weight loss. So let me write that. No hypoglycemia. No hypoglycemia. And they cause mild weight loss. So until now we have discussed 10 different targets in diabetes. Okay, so moving on to the next target. The 11th target is a drug by the name colesevelam. Now we have heard of this drug already, and that is in dyslipidemia. So it's a drug which is also known as bile acid binding resin. But here, why it is used in diabetes type 2? Because it inhibits the glucose absorption. Glucose absorption from the intestine. The 12th target, the 12th group of drug, they are bromocriptine. The name is bromocriptine. Now, what is proposed is in the early morning hours, there is sympathetic drive and that will increase the glucose activity. Sympathetic increases glucose. Now, this bromocriptine has shown to suppress that sympathetic drive in the early morning and decrease the glucose. So that is the mechanism proposed. Mechanism actually is not known, but this is the proposed mechanism. So bromocriptine is a D2 agonist. And remember, it's a derivative of ergot. And this is known to decrease the early morning sympathetic drive. And by doing that, it decreases the glucose. To achieve this, bromocriptine has to be used with low dose. And the release form is fast release form. So this is the one which we use in the management of diabetes type 2. So at the end of this, if you ask me the question, sir, why so many drugs? Remember, for managing diabetes type 1, we have mainly two drugs, insulin and pramlintide. For diabetes type 2, we have all these drugs. The reason is simple. The problem is insulin resistance. Even there is insulin, it is not able to work. And that's the reason we have so many drugs available in the market. What about any newer drugs? Let me give a glimpse of newer drugs here, which you need to know. The newer drugs is a drug which can stimulate both PPR alpha and gamma agonist. So what is the drug which is a PPR alpha and gamma agonist? The name is called saroglitazar. It is called as saroglitazar. You know that alpha is responsible in managing dyslipidemia. Gamma is responsible in managing diabetes. So the drug is approved in a patient with diabetes plus dyslipidemia. So it's a drug approved in India for managing both diabetes and dyslipidemia together because of alpha and gamma agonism. Another drug is the SGLT1 as well as 2 inhibitor, and the name is sotagliflozin. It is called as sotagliflozin. Third important drug, we have a drug which is dual acting. It's a GLP-1 as well as GIP receptor agonist. GIP receptor agonist. Now this GLP-1 stands for glucagon-like peptide 1. It's an incretin. One more incretin what we have is glucose dependent. It is called glucose dependent insulinotropic polypeptide. Insulinotropic polypeptide. So dual acting agent. The name tirzepatide. So it is called as tirzepatide. Again repeat the name tirzepatide. So it's a GLP-1 as well as GAP receptor agonist. So GAP stands for glucose dependent insulinotropic polypeptide. So what is incretin? Remember, whenever somebody takes the meal, so these incretins are released from intestinal L cells and they are going to increase the postprandial insulin. So in postprandial insulins, more than 65% are increased by these two. And these drugs are going to enhance that property that is called tirzepatide. And we have already discussed GLP-1 receptor agonist. Again, they can ask you, what is the GLP-2 agonist? And the name is called teduglutide. So teduglutide is used to manage, where do you manage it? Short bowel disease. Short bowel disease, the name is called teduglutide. So these are the newer drugs you have to keep a watch on. Saroglitazar, PPR alpha and gamma agonist, sotagliflozin 1 and 2 inhibitor, then tirzepatide, which is a GLP-1 and GAP receptor agonist, and GLP-2 agonist is teduglutide used for short bowel disease. Now let me give some specialties of these anti-diabetic drugs which are asked in the exams. The first thing you need to understand is, what about the weight? So what do they do with weight? It's a common question in your exams. Let us understand what drugs are weight neutral. So the drugs which are weight neutral are metformin. So metformin, some loss is also seen, but it is mainly categorized under weight neutral, and one more is DPP-4 inhibitors. Correct. The second important thing is, who will cause weight gain? Who will cause weight gain? Remember, it is the old drugs like insulin. Now SU stands for sulfonylureas, MG stands for meglitinides, and the pioglitazone. These are known to cause weight gain. Then what are the drugs which cause weight loss? Very much important. So they are GLP-1 receptor agonist, that is glutides, then SGLT2 inhibitors. They are known to cause mild weight loss, and a drug by the name pramlintide. Pramlintide. Correct. So we understood weight. So the next point I need to tell you about these drugs, summary. What about glucose? So please understand which of the diabetic drug cause hypoglycemia. The hypoglycemia is produced by insulin, sulfonylurea, and meglitinides. Only 3 drugs are known to produce this. And what about rest? All other drugs, they are called as anti-hyperglycemic agents. They are called as anti-hyperglycemic agent. That is rest all. Okay, so I explained that concept already. Then another important aspect after we know glucose. Now what are the drugs which are approved for both diabetes type 1 and type 2? So what is the drug which is approved for both? And they are insulin and a drug pramlintide. These are approved for both. And rest all the drugs are approved only for diabetes type 2 only. Very much important. Number 4, what drugs used in diabetes are used as injections? Very much important. And that's the reason why I started my videos, the first 3 drugs injection only. So even if you have confusion, if you know the first 3, it's easy. Insulin, except which insulin is not given as injection? Afrezza, because it's an inhaled insulin. Then GLP-1 agonist, except what? So it is semaglutide. Semaglutide, you need to understand, it is given as injection as well as oral. That is a specialty. And the drug is pramlintide. So that is the fourth point. Moving on to the fifth point, what drug has shown to decrease micro and macrovascular events? So what is the drug which has shown to decrease micro and macrovascular events? The beautiful drug of century, metformin. It has shown to decrease micro and macrovascular events. Okay, so we are discussing what about weight, then glucose, and then injection, diabetes type 1 and type 2. These are the points. Now, who will reduce maximum decrease in HbA1c? Now, maximum decrease in HbA1c is done by insulin. Then we have metformin, bar sulfonylureas. These are known to decrease the HbA1c, that is 1 to 2%. If insulin is not in the option, you can choose metformin, sulfonylureas, meglitinides. Rest all are known to decrease the HbA1c, that is less than 1%. So they will decrease it less than 1%. So this is the reason. The maximum is insulin, metformin, sulfonylurea, they can reduce by 1 to 2%. Rest all, they will reduce less than 1%. Okay, so these are the specialties what I had to tell you in the management of diabetes mellitus. Okay, so moving back to our case-based journey, we started our journey with the case 42-year male with polyuria, polydipsia and polyphagia. FBS is more than 180, yes, obviously. If it is more than 126, we tell it as diabetes. Postprandial also 250 and urine glucose 2 plus. Patient has diabetes type 2. Second-year-old and he has random blood sugar of 300. So here in type 2 diabetes, the best therapy is insulin. So if insulin is not controlling it, so we can add adjuvant pramlintide. A pregnant lady has ppps of 250 mg per deciliter. Gestation diabetes, for this the best drug is insulin. So what about diabetes type 2? So diabetes type 2, how do you manage? Now diabetes type 2, if I take that into consideration, diabetes type 2. So we tell the patient for diet modification. So less carbohydrate, more protein, and then regular exercise. And the starting drug in diabetic patients are usually metformin. So we start with single drug. If that is not getting controlled, along with metformin, we add the other group of drugs. So add other group of drugs. What are the other group of drugs usually added? DP4 inhibitors or SGLT2 inhibitors, right? Or the sulfonylureas are usually added. If it is not controlled with the two drugs, then triple drugs are added. Yes, still not controlled, then we have to go for the injections. Injections are given, particularly the insulin. So this is how the simplest management of diabetes. So most of the patients prefer to take injection. No, they don't prefer to take injection. Repeat from here. Most of the patients prefer to take oral drugs and they are not willing to take injections. Yes, so this is the management what we did. So here in this slide, what we discussed is the management of diabetes type 2. So summarizing this video in a nutshell, that is pharmacotherapy of diabetes. We started with a case and I told you how to differentiate diabetes type 2, type 1 and then gestation diabetes. These are three important diabetic types what they want you to understand. And then what are the different targets where we need to achieve the targets, what are the drugs in that. Then we discussed insulin, its preparation, uses, adverse effect. Then we discussed GLP-1 receptor agonist, pramlintide, and then we discussed the oral drugs and the specialty of them, and then what you need to remember for your exams. So that is about pharmacotherapy of diabetes mellitus. Thank you all.